O2 therapy or treatment. It's for any hypoxia. If the hypoxia responds to oxygen, it's a VQ mismatch. If it doesn't respond to oxygen, we're talking about a shunt. We've talked about this before, but what do I want you to understand as far as the FiO2, the concentration? Nasal cannula is the most common, most comfortable. 1 humidification. So we don't dry out the nasal mucosa and get nasal bleeding, etc. Okay? Now you can go up as high as 6 liters. For every liter, technically, add 3% to the FiO2, which in ambient air is 21%. So 1 is going to be 24, 2 is going to be 27, roughly, 3, 30, and so on. If you see greater than 6 liters in a Venny mask, that's telling you what the Venny mask is at. It uses the Venturi effect. So 10 liters is going to give you a certain concentration. The respiratory therapist here can tell me just by the color. But if you see a little color valve, just look at it and it'll tell you what liters and what concentration that gives you. He's not getting 10 liters. What he's doing is, if I breathe at greater than 6 liters per minute or 3 liters per minute, whenever I have this set, I am going to overcome my flow and I'm going to bring in room air. So nasal cannula is the easiest, it stays in the longest, or easier to take, or it stays in place, but we don't know the exact FiO2. That's when you use a Venny mask. People with hypoxic drive, which is, it's a misnomer, but we still call it hypoxic drive. Okay? Like I told you, if you're worried about hypoxic drive, get a SAT. Get a good SAT first and then bring it down to about 91, 92%, and you know you're going to be in the 60s at most 70s. So you're not going to be worried about that, about knocking out the hypoxic drive. Okay? Venny mask starts, unless you want to dial in, they have 28%, etc., but typically 40% greater to up to 70 or 60%. Okay? Then we have partial rebreather masks, 70% to about 80%. And finally, non-rebreather masks at 100% if you have a tight fit. Why do we get 100% there? Very simple. It's got 2 little valves. And then it has a bag, just like you would have it in the airplanes. That bag basically is full up of 100% oxygen. When the patient takes a breath in, that opens up and the side ports close so they get 100%. When they exhale, since they're exhaling CO2, the valve closes to the bag, no CO2 goes in there, the CO2 goes out the sides. So that's what makes it 100% oxygen. You better have a good tight fit. Notice if the patient, most patients, I avoid masks. Why? Unless I really need the FiO2, because most of the time they're going to take it, put it on their head, their ear. That's why the nasal cannulas are the most comfortable. Okay? So remember your FiO2 percentages. They cannot be on 10 liters. 10 liters, look for the FiO2 on the mask. Okay? If you overcame the hypoxia with oxygen, it's VQ, pneumonia, asthma, COPD. If you didn't, you got to be shunting, either intrapulmonary or more likely intracardiac. Or he may be in ARDS and you have to intubate, and we're going to use PEEP, etc. These are basics. Do your AA gradient, do your FiO2 or your PaO2 FiO2 difference or ratio. Remember the AA gradient? Just the simple way to do it is FiO2 times 7 gives you X minus your PaO2, gives you Y minus your PCO2, gives you Z minus 20% of your PCO2, and finally gives you your A, big A, little a gradient. That should be less than 25. It's affected by age, but anything below 100, 250, VQ. If you're all the way to the right, in other words, 600, 500, then you're talking about ARDS shunt. Simple approach. You just one step at a time, but be aware, once you have those little color masks built into the thing, that's a Venturi effect. Depending on the liters is going to give you a certain FiO2. Like I said, the respiratory therapist just know it by the color, but that's because they do it so often. But you just have to flip that thing and it tells you how many liters to get what FiO2. Any questions?